All right, let's get started. Good afternoon, everybody. I'm Mike Salvatore, the superintendent of schools in Long Branch, New Jersey. Welcome to our first video forum for moving New Jersey schools forward amid COVID-19. So what are we doing here today? We really want to focus on supporting schools throughout this process to make sure we can reopen on time and reopen in a safe and healthy way. What we're seeking to do is have 1-hour video sessions each week with experts from the field that can help guide us. Today, we have an expert on, and I'm going to tell you exactly who our guest is, and I'll tell you the structure of these. So each week, there'll be a 1-hour meeting. The invitations will go out through an email blast, typically through Facebook Live and through Zoom. The structure will be a back and forth conversation with somebody from the field, and the second part will be a Q&A. Because our chat feature is disabled for safety reasons, use the Q&A feature. You can always raise your hand and in the Q&A post a question. And then I can bring you in to allow you to talk and ask your question live. So without further ado, I want to introduce our guest for the next hour. He's dedicated some time to us and we certainly appreciate him. It's Dr. Lawrence Kleinman, known as a pioneer and national leader in children's health. I mean, we couldn't have anybody better here today. He's going to discuss the latest information that schools need right now amid COVID-19. And we have a whole list of questions for him. And this is especially important right now as schools are preparing to open partially for some summer and also for the fall. Just let me tell you, before we jump into the conversation, I want to tell you who's associated with this group today in terms of moving New Jersey schools forward. It really started as a brainchild from Professor Stephen Barnett from Rutgers University. So Steve, thanks for organizing this. He grabbed in some awesome people and we enlisted to make sure we can help steer this conversation. He grabbed well-known Dr. Penelope Latimer, former assistant commissioner, assistant superintendent of schools, and certainly very well respected in the field. Somebody who needs no introduction is our former commissioner of education, Kimberly Marcus. She is on with us today and has added valuable insight. So we're happy to have her on board as well. Hopefully I didn't miss anybody, but I think that's where the group started, and hopefully we'll add some more people as we go along. So at this time, we are going to bring on Larry. Larry, thanks for being here with us today. I appreciate you taking the time.
It's my pleasure to be here, Mike. And I need to say, when I heard you mention Penelope's name, my eyes welled a moment. She was a neighbor and a colleague of my mom's, so who was a longtime New Brunswick resident and activist. And so I grew up in New Brunswick, and I'm at Rutgers now.
No,
so thank you for having me here.
No problem, Larry. Every time I mention Penelope Latimer in any circle, I don't care where I am in any state, somebody knows her. It's because of the awesome work she's been doing. She's also a great person. So she's on with us today. Larry, I want to start with an important question here because a lot of our school nurses are talking about this. So I really would like to hear your take on it. So amid COVID-19 in terms of risks, we're all concerned about children coming back and being these secret spreaders, right? Who can come back and silently contaminate our teachers and that can spread it back to their homes and their families. Tell us about the risks associated with re-entering and the possible secret spread of COVID-19.
Sure, thank you, Mike. Well, I think what we have learned about COVID, and we are continuing to learn, is that children are not spared the epidemic. They can get sick from it and they can spread the infection. And some research I'm doing now suggests that they may play a very important role in spreading the infection. It seems that households with children are much more likely to experience symptoms of COVID than those without. So this is a real concern. And I think there are 3 underlying principles that I want to suggest are important for whatever the schools or really anyone does when they're going to be bringing children together. One is there does need to be some form of screening, which then allows one to isolate or quarantine the virus or the potential of people at higher risk at that moment from the general population. A second is there's a need to mitigate among children who are there. This is the social distancing, the masks, the hand washing, the frequent cleaning of surfaces, those sorts of things. And then there's also the need to reduce the opportunity for multiplication and super spreading by having large or interlocking groups. And I think it does remain an open question the extent to which these things can be sufficiently effective to make things safe for the fall. I think that's our hope, that's our intention, but we are all going to have to watch this and evaluate it and look actively to make sure that what we think is safe is in fact safe.
Can you hear my heart beating as you're speaking?
Yeah.
Because as a superintendent, when you talk about screening, mitigation, and super multipliers, I mean, oh my gosh, I'm getting a little anxiety. I need some of those SEL lessons that we've been doing. Certainly, those are going to be difficult to do in a school setting. And I know all of us have really good intentions in terms of my colleagues, but it's really important we're speaking to you right now because we're trying to figure this out over the next 60 and 90 days to make sure we open schools. Let me just move on to this in terms of, we know that there may be children who they're asymptomatic and they're coming into a school setting, but there's also people that we know who are high risk, whether it be students and staff. So tell me what would be the right way to go about on how to actually identify those at risk.
Well, I think there's a couple of issues at hand here, Mike. One is obviously there are confidentiality and privacy concerns that some families or kids might have. I think that means it may be important to communicate the definition of risk to families and ask them, without necessarily getting specific, whether they believe that anyone is at particular high risk. One of the things we know is that obesity alone seems to be an important risk factor, as well as age, diabetes, metabolic syndrome, cardiovascular disease. So there's a lot of stuff out there that can constitute risk. I also wonder, in the context of something such as school, whether the existence of different levels of risk and of risk tolerance in various families might suggest that there's some need to incorporate choice in terms of level of direct exposure, in-person versus distance learning, et cetera. And if so, how does one do that in a way that's equitable, fair, and effective for the education of children? I think there's a lot we have to figure out.
Right. So what you're saying is to provide an option to continue remote learning for those who are at high risk.
I think one has to at least think about that, or how one might do that.
Yeah. Yeah, I think it's something we're all throwing around right now, whether it be the at-risk teacher being at home and having a facilitator in the classroom with children, or the at-risk child staying at home and live synchronous instruction going on in the classroom, or some of the ideas out there. Thank you. But I think when it comes to risk, in order to identify the risk, there's certain factors, but what about even before that, just the daily screening? What are your recommendations there in terms of protocols?
So my feeling is that for both staff and students, there ought to be screening. It ought to be screening of symptoms and also the taking of a temperature. And I do think that one ought to ask about exposure to people in the household who also might have symptoms. Ideally, if someone screens positive, you would like to be able to test them and get a result so that you can have some information about whether they're exposed. There's an expense to that, there's logistics to that. It may not be possible, but that would be the better version. The basic version, I think, is asking questions about the child, the staff member, and their household exposures, as well as taking temperatures.
So ideal setting is everybody's tested routinely so that you can prove that there's no additional spread. But it seems like
or if someone screens positive, they're immediately tested. That would be also a component of that.
Gotcha. So it's not necessarily testing everybody, it's doing your pre-screening activities. And if somebody has particular symptoms, then they can go on for a test. That's probably more manageable when I'm thinking about running a school district.
Yeah, no, I think that's right. I think one wants to think what the platinum system looks like. It's everybody gets an antibody test before you come, and everybody gets an antigen test before they start, meaning the PCR, the looking for the virus. Then they get it on a periodic basis, weekly, every other week, and then they also get it if they screen positive. But that platinum is expensive, logistically difficult, requires a lot of consent and cooperation, and is likely more than pretty much any district could do.
Mm. You know, so some of the childcare centers open for essential workers, and what their protocols are pretty similar to what you're talking about. But one of the things that I thought was unique, which will be difficult to do, is to not only do a temperature screening upon arrival, but they would do one in the middle of the day as well. And I'm trying to apply this in terms of thinking about athletics opening up on July 13th. So July 13th, we're talking about being able to hold practices outdoor, and not necessarily practice, probably workouts. I just think about testing everybody coming in terms of screening temperature, no problem. But midway through a workout, would we see that their body temperature would increase beyond that 100.4 rate through a series of workouts? Or would that be exclusive for somebody who was experiencing some type of infection or fever?
I think that doing it in the midst of a workout without a cool down period first would be difficult to interpret. I do want to say, Mike, that I think a lot of this becomes a consideration of risk benefit and the balance therein. And I must say, I scratch my head and wonder. I mean, I've been an athlete. I was a high school athlete. I really wonder how some of the contact sports and even some of the workouts can be done safely. To me, I don't know the evidence that suggests that this is a good policy decision. And I think we need to be worried and maybe double down on our evaluation. One of the things that's important is you mentioned the essential healthcare workers and their children. To my knowledge, there hasn't been an active program to evaluate this. The state, I've been told, says, well, we didn't get a large report in cases in these children. But if the children were silent carriers, you wouldn't get that report. You wouldn't observe anything. And how would they know the extent to which their family members or other close contacts are getting it? So I think if you're going to do things, it's really important to build in an evaluation, both to know what's happening, but also to try to get real-time data so that things start to go badly, we can identify that quickly. I mean, we see now in Florida and Texas all sorts of reports that openings may have been premature. I'd hate to see that happen in New Jersey.
Yeah, I agree with you. So you have this sports enthusiast out there saying, hey, let's get back to some normalcy. At the same time, the idea of a contact sport in today on June 18th, without any data being able to resume some normalcy sounds a bit absurd, but I do agree with you. Let's walk into this instead of run into it. And let's take a look at data. That's what you're talking about, having the data out there that can give us some information so that we're not trying to create the data, right? We don't want to be the test case here.
Right. I think it's both, actually, Mike, because it's one, getting the data we can in advance, and two, building the data collection into our experience so that if one school district or a couple of districts see something, everybody else can learn from that, so we don't have to learn it again and again through people getting sick across the state.
Yeah, we all have seen the charts. If you haven't, they're out there in terms of states that were pretty wide open and the spikes that are occurring in the past week. So I think that's great information. Moving on to this. So with sports, there are spectators, and with schools, there are visitors. Tell me, what is your, what do you think about visitors coming into school amidst this virus?
Again, I think it has to be really important why they're there. And the mitigation and screening and other procedures also ought to happen. One of the ways super spreading happens is you have one person who's infected go from group to group to group. So if you have a specialist who comes in and meets with one group and then brings their expertise to another and then another, that's going to be a problem. Maybe that can be delivered electronically, even if they come into the school, but it's delivered through distance into the classroom. In some cases, that'll be possible. I think for parents and IEPs and other things, those same kinds of considerations may arise. Maybe there's a hybrid model, but I think that the need for them to be there has to so clearly exceed the potential for risk that the policy decision says this is beneficial, this is worthwhile. Even if it's a small marginal risk, we are willing to assume it because the benefit is that important.
So it sounds like, again, you're saying, hey, if it can be remote, that visitation to the school, if it can be remote in terms of maybe an IEP meeting or a guest speaker, then we should continue with that practice.
I think that's right. And I think there's a variation on remote, Mike. So if some people don't have access, perhaps they could come into the school, be in a room by themselves with a computer, and be meeting with someone else who's in another room by a computer, and thereby having the benefits without having the risks of sharing the space.
Well, that it kind of moves right into all the guidance, right? The concept of social distancing, which I think many doctors are saying, well, listen, you need to be physically distant. One, you don't have to necessarily be social or in a social environment. Just you have to avoid people. I mean, how long do we continue social distancing and other preventative behaviors before we can get back to normal?
I hate the answer to this question. It's until there's a vaccine or we have treatments that make it less dangerous. I have a 3.5-year-old daughter. Last night we spent the hour after she went to bed talking about her desire to go back to school. She was very excited because we decided we were going to cohort together with my sister, her aunt. So she was held by her aunt for the first time yesterday in quite some time. And then she was wanting to know about going back to school. We call COVID for her the bad cold. I don't know what better to do, but that's what we've done. And so it's really important to simultaneously communicate the abnormality of the situation with the fact that the risk continues. And I think the risk is going to continue for a bit. I immediately before this coming on this webinar, I was listening to a talk at Robert Wood Johnson Medical School's Pediatric Research Day on an update on vaccines. There are reasonable candidate vaccines. There are human trials going on. We have not seen the data, but there is at least the possibility that a vaccine might be approved late summer, early to mid-fall. And some of the companies are already ramping up manufacturing the vaccines in hope that the trials will go well so that they can ramp up and distribute immediately. That's the best hope. But it is not going to happen before school starts. It's going to be a while. It could be another 4 months, 6 months, or longer.
Wow. I think, does the world know that? Because we're looking at summertime in New Jersey, we're looking at beaches and boardwalks crowded and people, and then eventually schools or sports opening, and everybody's got to keep their distance. I think we've got to make sure that we are constantly telling people the importance of keeping their distance physically and socially. So I think we've got a lot of.
I think that distinction between physical and social distancing is really great to make. It's not that we're apart from each other. We're actually all in this together. And yes, I do think that messaging is very important. I think the New York Times did a piece on epidemiologists and infectious disease docs. And it was clear that a survey of 500 and some of them, they're not reopening as fast as the rest of the world because they know too much. And the reopening the closing was science-based. The reopening is not. It's seat of the pants, it's guts, it's pressures, it's the economics. I mean, it is absolutely true that shutting down the economy has hurt a lot of people very badly. And the government has not stepped up to mitigate that sufficiently. And I think governors are responding to that. So rather than commenting on the wisdom of the decision, which I'm not in a position to do, I do think we need to recognize that the consequences can be very bad from a health point of view. And that's why it's on each of us to maintain that message, develop the best processes and procedures we can to reduce the risk, and then to do surveillance and to be looking for problems so that if they happen, we can provide data to change and inform the policies moving forward. It's a really complicated and very tragic situation that we're all just trying to cope with, and none of us feel good about.
Well, you said the word if, as if only one person were to be infected, but the reality is, right, Larry, we know we're going to open schools at some point, and somebody in that school, while we have the full population, will test positive. So what do we do with that scenario?
I think the way to think about this is to be proactive, in part because the information is changing all the time. I would suggest that either each school district or maybe groups of school districts should engage in advance with an infection control expert, presumably either a pediatric and adult infectious disease physician. And so that when that happens, they have a plan, and that plan can be updated periodically. Certainly rooms need to be cleansed. It is absolutely fundamental to the public health process to do contact tracing, to identify, who has been exposed most closely, and then the people whom they've been exposed to, so that people can be informed and those individuals can be isolated. Rooms and spaces need to be cleaned and disinfected before reopening. There's also a psychology to this. So does that psychology mean a building should be closed down for a day, whether that's required or not, or 2 days? Or is it simply what the current best infection control processes are at that time? I think these are decisions that are, like much of this, there's both art and science involved.
Which means there's a lot of gray area, Larry.
I hate that that's the answer so often.
No, that's we completely understand. So what about just simple protective equipment? Everybody's talking about PPE. Everybody's got masks with logos and buttons and breathing apparatus on there. Tell me, what do we really need to get people back into a work setting, particularly schools?
Well, we need masks, that's for sure. I think gloves offer certain protections, but they're a double-edged sword. People don't wash their hands with gloves on them, so they may actually spread more once they do it, but they protect the wearer while they're wearing it, so long as they don't touch their hands or their face. But having gloves for anything that's expected to be contaminated would be worthwhile. For childcare settings and places where you have small children, you need to hold them. Some form of a gown or other protective clothing might be beneficial. Goggles and face shields or face shields are recommended if you are in a room with someone whom you believe may have exposure. In other words, if you've got what they call a person under investigation. I don't really like that term, but that's the CDC's term. So I would say there, gowns, booties, head bonnets, goggles, and an N95 mask in that case. And those are hard to obtain and expensive when you get them. I think that if nurses or school nurses are going to be doing testing, or anyone's going to be doing testing with a nasal swab, probably a face mask and an N95, a face shield and an N95 are indicated. There's also the saliva spit testing that doesn't require that same level of care and handling. But I do think that the mask is the basic piece of equipment. The mask and 6 to 10 feet between you and others, and not mixing groups. And that becomes difficult in a high school, right? Where the English teacher and the math teacher, students may think they look alike or sound alike, but they're usually not the same. And so that's another opportunity where you may want to have proctors or facilitators in rooms who are the same people with the same children every day, and have the teachers presenting electronically, because the mixing becomes the problem, the opportunity for super spreading.
Oh, sure, sure. I mean, I think about being a former preschool teacher with 3 and 4-year-olds where we were blowing their nose and, wiping food off their face. That's going to be certainly a
Right.
real challenge. It's going to look like a hospital, I guess, if people are going to have that level of protection in terms of shields and masks, gloves.
And the question is, how can we do it in a way that doesn't just frighten the children, right? That's, the joyful logos, the smiles, the other things that don't make this a cold, sterile hospital environment. The whole purpose of preschool is to create a safe environment for enrichment for children, right?
Mm.
But safe is critical.
You know what I've also learned about young children is they're so adaptable. I mean, I
Yes.
know people say, oh, we're concerned the kids will be scared. I actually think with that population, they're so flexible and adaptable at that age, and so intrigued by learning that it might even be easier for them to return in terms of observing the structure than some of our older children in our intermediate or high school level. Larry, I want to get another question to you. And these are probably all around having large groups together, whether it be on a bus, in an assembly, I kind of know what you're going to say here, or feeding children. Any advice to schools on how to keep kids distant during these big group times of where they're congregated?
Yeah, I think that the school bus issue is a real issue. Particularly now that buses don't have windows that open so much anymore, because fresh air is a good thing in this. But if windows could be open, that would be good. Wiping and cleaning surfaces between uses, maintaining distance. One child on a seat, empty seat, one child on a seat, or siblings, people who live together. The capacity changes in really important ways. And I'm worried about transportation and buses. I think also the procedures for unloading and offloading, arrival and departure in school requires more structure and less mixing and not that chaotic, wonderfully chaotic mixing of families and children and the social aspect of it. It's got to become more regimented, unfortunately. And I think in terms of feeding, I think cafeteria lines are harder, maybe not impossible. Maybe providing sanitizing wipes if you're giving out plates, or even for handling boxed lunches, which may be a better way to distribute, an easier way to distribute. Certainly you need, if you have a line and cafeteria workers serving, you need the equivalent of a face guard, a face shield, I guess a sneeze guard is what it's called, or cough guard, as like the salad bars have in restaurants, to protect and create some distance. And then these services need to be cleaned very frequently. But I think also the wipes, having the wipes, sanitizing wipes, maybe older kids could use sanitizer itself, but younger kids are at risk of poisoning and ingestion. So I think that these are real considerations, and nothing is easy about this.
Yes.
Wiping surfaces between each class, between each sitting as well.
It sounds like a whole new way of doing school, right?
It is. And so I was a history major at Rutgers, and I read a book called So Human and Animal by Rene Dubos, who was with Salman Waxman at Rutgers. And he talked about how it wasn't the germs, but the mixture of germs with a susceptible host. And so I never grew up terribly afraid of germs. This isn't how I thought of the world. I have relatives, a niece who's in the hand sanitizer business. She thinks very differently. In this environment, her thinking holds. My thinking is not adaptive to this, because it is about the germ and keeping the germ away, and then washing hands very frequently, because the germ on your hands is not likely to get you infected until it's brought to your face, or brought to somebody else's face, or to another surface that brings it to someone's face. So there is opportunity, even if you're exposed, through hand washing and hand sanitizing, to mitigate the potential for spread and to reduce the exposure. The number of viruses that you're exposed to matters. So building that into the thinking is useful.
Well, Dr. Kleinman, Professor, Vice Chair for Academic Development, Director, Division of Population Health, Quality, and Implementation Sciences in the Department of Pediatrics at Rutgers Robert Wood Johnson Medical School. If that wasn't a mouthful, I don't know what was. Dr. Kleinman, Larry, thank you for joining us today. Can you stick around for some questions?
I'm happy to stick around. Thank you, Mike.
That was great. You really you helped frame a lot of things for me and hopefully for our audience. So I'm going to take some time. And we have a couple questions in the box here, and let's see what we have. This is from our good friend, Penelope Latimer. Does Dr. Kleinman have an opinion on how much digital learning is appropriate for youngsters? And does this vary by age level? And she also wants to say hello.
Yeah.
So Larry, you think you could answer that?
Of course. Hi, so good to hear from you. So I think this is a difficult question because we don't know, because we've never immersed children in digital learning at this level. We know that the exposure to the screens seems to change brain function and brain waves in certain ways. We don't know if that's a permanent or a momentary change. Younger children and many other children have limited attention spans. So it may be that when they're not in an environment and they're attending to an environment, there have to be more frequent breaks. It may be that spaced learning and small bites of information are more effective. But we are figuring this out as we go. We are changing the tires as that car is moving down the street. And that's inexact. But it also provides an opportunity for measurement, evaluation, research to help us to understand these things better.
You know, Larry, just to complement that, there's a lot of the research that I was taking a look at in terms of screen time. We keep hearing about blue screen and screen time, but it's really about the fact that when you're not engaged with people, you lack certain skills, or you're not able to develop certain skills. So whether it be social skills or language, and that's the impact that screen time has. It's typically taking you away from engaging with other people. So just to complement that, I hope that helps Penelope.
And I think that's right. The other point that they found is that screen time that's engaged with parents or family members where there's interaction is less harmful, or less, I shouldn't say harmful, is less associated with some of the negative findings than when it is more engaged.
I have a question here regarding face shields. Are they actually better than masks? They seem easier. It looks like they can clean them better. You know, what is your take on that?
Face shields are a complement to masks. They're not a substitute, because the droplets can get stopped on the spray shield, or they can be carried by the air currents. And so you want to use the mask even if you're using a face shield. There are times when you want to use the face shield in addition to the mask. So.
Great. What about, let me see, I'm going to try something new here, Larry. It looks like we can have them, I can pull them in here. It seems like Roseanne, we can answer live here. Roseanne has a question. If children return to preschool and masks are suggested, is there any benefit if some children are wearing masks but others aren't?
The answer is yes. The mask fundamentally protects others from the wearer more than it protects the wearer from others. N95 masks protect both. But a surgical mask might protect you from 50, 60, 70%, depending upon its composition, of exposure. But it protects others from your forcible exhalation, and therefore limits you to that 6 to 10 foot distance that we talk about. Without masks, it's actually a much larger distance. And that's something that's not well understood. Singing and cheering and other things, forceful expiration takes it even further.
Yeah, I've just watched, I've watched different people with masks, and it does seem that after a certain time, that mask slowly starts hanging around their chin because they need that airway. And I've also watched people with shields, and depends which type you have, it seems almost a bit more comfortable. So I don't know which one's better there. Do you have a preferred method?
Oh, I think the mask is necessary. And if someone needs a break, they should go into a private space and take it off, but it's really not okay. I went to a restaurant not long ago, picked up some ice cream for my daughter, and it was late in the evening, and the guy had the mask around his chin. He said, "Hope you don't mind, I just had to get a break." And then he opens the bag and looks in and breathes, then closes it and says, "Yep, this is yours," and hands it to me. I wiped everything down and washed my hands.
I think we've all been in a situation, at least in the past couple months, where somebody has done something where we're all hypercritical. We're all questioning whether that was the right thing to do at the time. And sometimes we're leaving that to be decided by maybe a 16-year-old behind a counter serving ice cream. I just want to open it up. Are there any other questions? Because I don't want to take any more time from Dr. Kleinman or Larry.
I see a question about the temperature check in there from Michael Hunter.
Oh, okay, yeah. Okay, who is qualified to do the temperature check? Is it just nurses, or can anybody do it?
If you get a machine that is a no-contact thermometer, that's accurate. Anybody can be trained to do that. And one can record them or not, or just screen and let someone enter. But it's not a technical skill. It's not like taking an underarm or a mouth temperature where there is more care. But if you get a reading that doesn't make sense, it should be repeated. So if you get a reading of 91 degrees or 92 degrees, repeat it, because it should be, around 98 or higher.
Everybody's inbox is flooded right now with COVID-19 protective elements. What advice would you have? Because we really don't know. We're not doctors, and we've been thrusted into this environment. What's the right device to use right now?
Well, I went to a local medical. We had some work in our house that had to be done. And I went to a local medical supply house and bought a thermometer that they sell to physicians. That was a contactless thermometer. I think that's the kind of thing that would be good, a contactless thermometer that is designed for a medical officer or medical practice. It's more likely, in my mind, to be accurate. But they do publish the specs, plus or minus, and the one I bought, I think, was 0.5 degrees. I didn't see much more accurate than that.
That's good. I'm just going to start sending my stuff to you then. I'm going to say, Larry, vet this for me. Tell me if this is the right thing. Another question. Another question. It came in from Peter Hughes. Actually, Pete said it was excellent. But Eva has a question about children using toys. As you know, you have a 3.5-year-old daughter, Larry. They touch everything. They put things in their mouth. They touch their eye and touch the toy. I mean, how safe is the preschool environment with all of this discovery learning?
I don't think I could say it's unqualified safe. I'll leave it there. My daughter loves stuffed dinosaurs. I think I would not allow soft, plushy toys in the preschool environment. I think things that can be wiped down, and folks need to do their best to wipe it down frequently. If the kids are interacting and are together and they're breathing on each other and they're touching one another, which I don't think is ideal but may be necessary, then sharing a toy is no worse than that. But it should be washed once they're done with it, wiped down with an antibacterial, left on it for the appropriate dwell time, which some of these is 30 seconds, some of these is a few minutes, and then put back in circulation.
That certainly will be a challenge for those early childhood classrooms out there.
It's terrible.
But great advice. I also have somebody asking about children with special needs, particularly children with autism or medically fragile students in regards to sessions in school. Many of our parents, from my perspective, are asking for help. They want their children back in their school environment because they know they do much better with the structure and the support. Any considerations there or input regarding our fragile or special needs children?
I think it's difficult. The kids who are medically fragile are the ones who are more likely to get very sick. I was a part of a study looking at pediatric ICU in the first couple of weeks of COVID around the country. And I think somewhere around 40 to 50% of those who were in the ICU were medically complex kids, medically fragile. A proportion were obese, heavy, and about 1 in 5 did not have a pre-existing condition. So I think one has to be wary of that. For the kids with autism or on the autism spectrum, I don't know of any reason why they are at higher risk to get COVID. And it may be that they are at greater benefit from their socializing experiences in school, so that when I said that I thought one needed to individualize the balance of risks and benefits, it may be that for some children, the benefit piece is larger, and therefore the families may be willing to take on more risk. I don't know of evidence or data to that, but I think one can make inference that that's likely true.
Oh, thank you. Thank you very much. I want to invite Dr. Latimer, and she has another question I think is really important. Penelope, we can hear you if you unmute and you want to ask your question regarding stress and anxiety in schools. I'm going to unmute you. Hold on. All right. Hi, we can hear you.
Hi. Hello again, Larry. It's so good to see you.
And you, Penelope.
Yes, so I'm interested about how we can help the parents to manage the stress of all these changes in schooling for both themselves. And this is a whole different kind of schooling and learning for the parent, and then how they can help their youngster with adjustment.
Yeah. First of all, I think we have placed too much of a burden on the families without thinking about its 360-degree implications.
Right.
Especially for those who are still working or trying to work. It's been very, very difficult. It's a really important question. I don't have a lot, but this is what I have. What I try to do is emphasize to parents what is in their control. There's much about this situation we can't control. They can control the social distancing kind of things. They can say, X is too much, I can't do something, and my child is not going to participate in this. Or X is critical, and I'm going to prioritize this for my child, and I'm going to give up certain things on my own. And I think that recognizing that there's much out of control and helping and empowering them to assume control where they can, including absences, decisions that go against what they might perceive as the social norm, it is really, and giving permission for that explicitly is a way to help parents feel that they are somehow not failing by not doing everything that one might do, and also letting them know that they have a role in this and their role is critical, including using their judgment every step along the way.
Well, I think that's really marvelous feedback, and what I think parents rarely hear, that they have a role in this and they can put some controls on how much, is too much for the family. One of the things that I've been concerned about with this quick pivoting is we've seemed to have gone back to the 1950s and think that it's parents and two children in the household instead of crowded homes, different levels of children that the parents have to be concerned about. They may have a middle schooler, a high schooler, and a early childhood learner.
So I think that's very real. Now, Let me just throw something out there. I didn't have this, I wasn't planning to say this, but I've developed a survey that has different modules that include stress related to COVID, unmet medical and unmedical needs, social determinants, health exposure, and a number of other things, neighborhood, collective efficacy, the adequacy of the medical home for the family, their perception of the importance of a particular organization, such as the schools in their lives. And I would be happy to work with anyone if they felt this was something that they would like to explore to see if it could be used. I'm happy to have it used operationally or to use it in a research setting. But if it's a benefit, Mike knows how to get a hold of me, and I'd be happy to make myself available to any or all of you if that would be useful. I also realize I probably should have said something before when Penelope, I'm sure, recognizes my last name because of my mom. But my mom called me Chuck and not Larry or Lawrence because I'm a Lawrence Charles. So if that's been floating in your head, Penelope, that's why.
That's so true. Yeah. I have such fond memories of Gert. She was wonderful.
Thank you. She actually created something that was a precursor to Head Start in New Brunswick many years ago down in Memorial Homes. So,
yeah. Thank you very much, Penelope. Larry, if you're interested, we got a couple more questions, and they're pretty good. Of
course.
So
I'm here for you.
One of them are about masks. Just a simple question: the disposable mask. You referenced the N95 mask. You know, is there a difference? And should kids be bringing them from home, or should schools be handing them out? You know, what preference do you have there?
Well, I mean, N95s are better, but I can't get a hold of them. Our hospital system is limiting exposure, so I think that's the reality. I think that the schools should have them available. One is because they are an expense and some families might not. I think if kids bring them in, that's okay. If they get wet, they should be changed. One also needs to be careful. There is an art to doffing and donning a mask, right? If you grab the mask and the full face and you take it off, your hand is now fully exposed to everything your mask has been exposed to. It's behind the ears or behind the head and then removing. It's a good idea to wash your hands immediately after anyway, and before putting a new mask on, or to hand sanitize. So these are the kinds of things that aren't spoken of in the public discourse regularly, but actually make a difference and increase the effectiveness of masks.
That's so important to schools. I'm so glad you said that, because you're right. Just if we assume that people know how to put on a mask, I actually watched a video of a governor trying to put a mask on live, and he was putting it on completely backwards. Never mind taking it off the right way. So
right.
That's great input. Last thing that we all keep hearing about outdoors, being outside, and there's some assumption that being outside is safer than being inside. So what do you think about classes being outside as opposed to inside for the fall?
Wow, I hadn't thought about that, but it's a great idea. A synagogue I belong to and that I've been helping to advise is doing socially distanced, limited, reservation only outdoor services under a tent. Okay, so I think outdoors is better. It is in fact safer because the wind currents don't concentrate the virus in the same way this happens inside. You're not recirculating virus through a ventilation system, which is a whole nother area of study that we are just beginning to learn about. So I think outdoors is likely safer. The surfaces may not be much safer, but the exposure and the presence is likely safer. So I think that's a good idea.
All right, so outdoor it is. Hey, Larry, when we're going through crisis training as superintendents, one of the things they teach us is that if there's ever a chemical spill or something in a school is to shut down the ventilation system immediately. When you just mentioned about the ventilation system, it made me think about that. Should we be considering, because we typically bring in and circulate fresh air throughout the building, should we be considering limiting that ventilation system's circulation of air throughout the building?
Yeah, in the modern buildings, that's really hard, isn't it? Because the windows tend not to open. Fresh air is better than recirculated air. That's for sure. If there's a capacity to add a filtration, particularly a HEPA filtration, that will reduce the transmission of the virus. And I know there are people who are studying these issues now, and I don't know the results of those studies.
So I would assume hospitals probably have the most knowledge of this right now, because they have to have probably the highest level of filtration in their air circulation.
And if you have a patient who has COVID and you have sufficient capacity, which the hospital systems have not always had, you would put these patients in rooms that have a specific flow of air in, but the flow out is directly vented to the outside. And these rooms exist routinely in hospitals, but there's a limited supply of them. But that is really the state of the art for when an infection is present. Obviously, we're looking to screen and to the best possible exclude people who have active infections in the schools. So I don't think that's what's necessary. But improving the ventilation may be valuable. And this may also be where an infection control consultant might be able to offer some guidance more than I can in terms of the specifics.
So what I heard today were masks are good, temperature readers necessary, toys should be washed or sterilized, sanitized, cleaned, ventilation systems. Hey, if you can get outside, get outside. If you can open the windows, open the windows. Listen, Larry, great tips for us today. And you combed through so many different areas over this time. I really appreciate you being with us. I just want to let everybody know that next week, Larry's not going to be with us next week, but he's welcome to come on board. But we will be meeting next week to talk about a different topic. And let me just see what we're going to be talking about next week. So we are going to be next week, mark your calendars for identifying the most pressing needs for information for school districts and how districts can get answers to those questions. We're going to send out another blast later this week or early next week. So please jump in if you found this meaningful. Spread the word to your peers and colleagues out there. Larry, any parting words before we head off?
Well, first of all, thank you, Mike. I mentioned to you beforehand, but I'll say this: I suspect this is the most important call I'm going to do in a long time. I really wish everybody luck. My feelings are with you. Mike, you should feel free to share my email address. If my survey would be helpful, I'd be happy to engage with folks to figure out how to use it in a fruitful way. It wasn't designed for the educational system, but I don't see any reason why it couldn't apply there. And this is really important, and you are entrusted with safety and measures that are not fully within your control, and similar to what parents do, you have to do the best you can. Watch and listen for if you see actually, I'm going to make one more point. Part of what I do is quality and safety. And one of the tenets to a safety culture is one that is non-punitive. It has to be safe for people to identify where policy doesn't work, or for people to report that folks are not following policies without there being huge consequences. Because otherwise it gets buried underground. And it may be that the policies could be tweaked or the resources could be tweaked to make it much more acceptable. And also, those become instances for learning. If they become the sources of outbreaks, it's useful to know that rather than it being simply the policies don't work. So I think the extent that you can listen and create a non-judgmental, safe space for people to provide information about COVID, its mitigation, adherence, and deviation from policies will serve you in the long run, even though it may go against some of the grain of compliance that we all have as as licensed professionals. So, but I do think that that is important, and I think it will benefit you in the end. Other than that, I really want to say thank you. I'm very grateful for the opportunity to talk to you. Thanks to Steve for connecting us. And Penelope, it was really wonderful to hear your voice. I hope to see you soon. Do you still live where you used to?
Oh, she can't speak now.
Oh, she can't speak now. Well,
I'm
I still
sorry.
get down to that neighborhood if so.
Dr. Larry Kleinman, thank you very much again on behalf of Stephen Barnett from Rutgers University, Penelope Latimer, and former Commissioner of Education, Kimberly Marcus. We thank you for taking the time out there, and the participants, I know a lot of positive feedback. So thank you very much. And we look forward to seeing everybody next week. Okay. See you, Larry. Thank you.
Thank you so much. Take care. Bye-bye.
Bye-bye.